there are still many unmet needs in the field of NET research. I think, as I'd mentioned before, we are fortunate to now have a number of treatments available for patients. I think one of the unmet needs is really determining the optimal sequence of therapies. And there are some ongoing studies trying to evaluate that, especially on the international level, looking at sequencing of chemotherapy versus biologics versus PRRT, and we're eagerly awaiting the results of some of those studies. In addition, PRRT, as I'd mentioned, has really been a game changer in this disease, and I think that we're eager to look at how to optimize PRRT, whether that is minimizing side effects or making it more effective, or applying it to other less common NETs. So for example, there are some upcoming studies looking at 177 ludotatate in patients with paraganglioma and pheochromocytoma, also in lung neuroendocrine tumors, which was not included in the FDA indication that was approved 2 years ago. I think we're also looking at using other radiopeptides, somatostatin receptor agonists as opposed to antagonists. And so there are a number of different ways of looking at PRRT, which I think is exciting. In addition, there are also agents that can take advantage of the somatostatin receptor itself. So looking at bispecific antibodies or antibody drug conjugates, I think somatostatin receptors are really one of the perfect targets because they are very specific to neuroendocrine tumors. And there are a number of companies looking at other ways to take advantage of that specific target. I think I'm eager to also see further work in immunotherapy in neuroendocrine tumors. I think that NETs to date have proven to be not particularly responsive to immunotherapies. And I'm speaking specifically of the well-differentiated grade 1 and 2 neuroendocrine tumors. They tend to have a very low mutation burden, and single agent checkpoint inhibitors have not been particularly effective. So I think there are a lot of questions around how can we change NETs, which tend to be a not very immunoresponsive tumor type, into one that could be. Are there ways to use combination therapies that might turn NETs into an immunoresponsive tumor? Grade 3 neuroendocrine tumors are also a really unmet need. There's an ongoing clinical trial through ECOG-ACRIN that's looking at platinum etoposide versus temozolomide and capecitabine in grade 3 neuroendocrine neoplasms. In addition, I think immunotherapy may play a special role in that subset of neuroendocrine neoplasms just because it may have a higher mutation burden, tumor mutation burden. So there are some ongoing studies that will likely evaluate immunotherapy in grade 3 neuroendocrine neoplasms. I'm really eager to see what the next 5 years looks like for NET research. I think we've accomplished quite a bit in the last decade. And I think it's really interesting to reflect back on that period of time because really prior to the mid-2000s or early 2000s when we started having some new FDA approvals, NETs were really considered so rare that they were not worthy of doing large phase 3 clinical trials, or rare enough that we couldn't accrue patients to these trials. And I think what the last decade of research has shown is that they are in fact a disease worth studying. We can enroll patients on these studies. And NETs are actually not as rare as we think because patients with NETs, the grade 1 and 2 NETs, often have a more indolent disease course and live for a long time. It means that they are more prevalent than some more common cancers like gastric adenocarcinoma and pancreatic adenocarcinoma. So though the incidence is low, meaning the number diagnosed per year, the prevalence is quite high, meaning the number of patients living currently with NETs. So I think it really means that we need to engage more young researchers in the field. We need to train community oncologists how to take care of these patients because they will encounter them in the course of their practice. And so I'm eager to see the next generation of clinical trials, and I really think that they will include more evaluations of PRRT and more novel therapies.